Hello, today my topic is episodic ataxia, and I would like to talk it under 6 subheading. This is outline. First, let's see the importance of finding out the etiology of episodic ataxia, then about relevant channelopathy, then I'll describe a story happened in 1975, then I'll summarize about episodic ataxia type 1, then I'll describe a story happened in 1946, then I'll summarize about episodic ataxia type 2. Then first topic, why we want to find out the etiology of episodic ataxia, because most are treatable. Then to prepare this presentation, most of the information I took from this systematic review done by Anha Hassan, and with pain respect toward her, let me continue my presentation, and I put the link here. Okay. We can divide the etiologies of episodic ataxia like primary genetic episodic ataxia, secondary episodic ataxia, and episodic ataxia mimickers. First we'll see the list of episodic ataxia mimickers. It can be migraine, vestibular disorders, anxiety, functional disorders, seizures, transient ischemic attack. Likewise, list is going on, but sometimes true episodic ataxia also can be mistaken as functional. Then, when we consider this orange box, secondary causes of episodic ataxia, I want to highlight comparing the secondary causes of episodic ataxia and the primary causes, the more common group is the secondary causes. So there's a huge list of causes under secondary causes, which we'll see in coming slide. Some common features of secondary causes of episodic ataxia are onset after adolescence and negative family history and greater attack variability clinically and radiologically and laboratory-wise abnormal investigation. Now, those are secondary causes. Now we are moving to primary causes. Primary causes can be primary genetic episodic ataxia, or it can be other genetic diseases which can present as episodic ataxia as a secondary manifestation. That is in the gray color box. So there, it can be chronic ataxia disorders, genetic epilepsy syndromes, or glutathione deficiency, mitochondrial disorders, or metabolic disorders like urea cycle defect, biotin metabolism defect, thiamine metabolism defect. There can be a lot of causes there also. But today, I try to focus on primary genetic episodic ataxia, that is in this blue color box. They were named according to the chronological order of the gene or chromosomal locus identification sequence. Okay, so they were named according to like episodic ataxia type 1, type 2, type 3, like as they went up to type 8, now type 9 and 8 and also there are suggestions. Then this talk is mainly for education basis only, it's not a medical advice. So now we are moving to treatment. I like to stress that. Then treatment of episodic ataxia type 1, it's mainly by carbamazepine. Type 2 acetazolamide, type 3 acetazolamide, type 4 gabapentin, type 5 acetazolamide, likewise list is going on. Now we move to secondary causes of episodic ataxia. There are a huge number of causes which subcategories, like it can be metabolic, it can be inflammatory, autoimmune, toxic, vascular. So under that also there are subcategories. Depending on the exact etiology, the treatment will be different. So that is the importance of finding the etiology. Today our topic is mainly targeting the primary genetic episodic ataxia, and during my presentation I will take you to the outline slide again and again, and when I cover a subtopic, I rewrite the subheading with purple color mentioning the point we discussed in that subheading in previous slide. So up to now, we discuss importance of the finding of the etiology of episodic ataxia as most are treatable. Now we are moving to second subheading, that it's a channelopathy. That means genetic episodic ataxia, mainly they are due to channelopathy. Among them, episodic ataxia type 1 and type 2 are the commonest episodic ataxia, genetic episodic ataxia in the world. So either it is due to potassium channelopathy, either due to calcium channelopathy. How to remember which one belong to which? There's a easy way to remember. Potassium is a 1 plus, calcium is a 2 plus. So I remember it as episodic ataxia type 1, potassium. Episodic ataxia type 2, calcium. Because potassium 1 plus, calcium 2 plus. I think it's an easy way to remember to anyone. Then now I'm taking you back to 1975 about a story happening there. Okay. Here in this journal by D.H. Van Dyke and their team had described in this journal about 3 consecutive generations of families who have hereditary myokymia and they observe it's in autosomal dominant in nature. And they develop episodes of ataxia with the vertigo that has lasted only for few seconds or minutes. And those episodes were triggered by several factors. In between episodes, they had persistent myokymia in the base of the limb. And it takes around 20 years for technology to develop, and later another scientist has found out the responsible locus in the chromosome 12 in the long arm here. Then later relevant gene is identified, it's KCNA1 gene. So now we are moving to our outline slide. Now up to now we know the importance of finding the etiology of episodic ataxia because those are treatable. It's a channelopathy, EA1 1+, so potassium channelopathy, EA2 2+, so calcium channelopathy. We described the first description of episodic ataxia type 1 that has happened in 1975. Later how the gene is discovered. Now we are going to summarize about episodic ataxia type 1. It's a potassium channelopathy. It's Kv 1.1 channel. It has a key role in neuronal excitability in central nervous system and the peripheral nervous system. Fast voltage gated channel. Responsible gene is KCNA1, but there is no genotype-phenotype direct correlation. Even with the same mutation in the KCNA1 gene, even within the same family, even within the twins, the manifestation phenotype is different. Why? Is there any environmental factor, any modifier, any problem? Yes, because there are triggers for the attack. Physiological stress, psychological stress, food like caffeine, alcohol, sudden movement, kinesogenic trigger, startle response, like several other causes can trigger the attack. So even within twins, even within same family members, the phenotypic expression of the disease can vary because the attack frequency also can be vary between the twins also. Then symptom size, classical onset in the childhood at the age of around 8 years. It is a brief attack of ataxia and the vertigo which lasting for second to minute. And frequency can be vary, maybe daily, maybe monthly, it's also varies. Some develop other symptoms during attack like double vision, slurred speech, nausea. Now in between attack, these people have constant myokymia in the face or the limb. Investigation wise, their MRI brain is usually normal. But with the disease progress with time, they develop constant ataxia, and by that time they can have cerebellar atrophy. Other investigations, right? Some blood investigation done to rule out other secondary causes, and EMG to look for the myokymia. And genetic testing in the episodic ataxia type 1, there can be some problem because compared to the general population, people with episodic ataxia type 1, KCNA1 variant, people with that variant can have higher tendency to develop epilepsy. So even though we diagnose a patient with episodic ataxia type 1, some episodes may be actually seizures. So other thing is EA1 phenocopies also can be there. So existing treatment mainly anti-seizure medication, carbamazepine, penetrone and the lamotrigine, but medication response can be variable. So we are moving again to outline slide. Now we know the finding the etiology of the episodic ataxia, the important is the most are treatable. Primary genetic episodic ataxia are channelopathies, and potassium channelopathy for the EA1 and calcium channelopathy for the EA2. We know the first description of the EA1 happened in 1975, and in summary, EA1 is short-lasting ataxia with the vertigo, and they had myokymia in between this episode. Now I'm taking you back to a story happened in 1946. In that time, they have found families with sudden ataxia and the dysarthria spells that lasted for hours, and they were also triggered by some factors. In between those attacks, they had nystagmus. After around 50 years, they found the relevant chromosome in the 19p, and later the CACNA1 gene identified as the responsible gene. Okay, so now we know what is up to now. We discuss episodic ataxia are treatable. That's why we want to find the etiology. It's a channelopathy. Potassium for EA1, calcium for EA2. We talk about the story happened in 1975, and then EA1 is a short-lasting ataxia with the vertigo. In between attack, they had myokymia. Now we describe about the EA2. They had a long-lasting ataxia with the dysarthria. In between attack, they had nystagmus. To describe more about the EA2, I would have to tell you about something about spinocerebellar ataxia type 6 as well. Okay, we'll go to the last subtopic. Okay. Now EA2. EA2 is the commonest genetic episodic ataxia in the world. It's a calcium channelopathy, problem in the CAV 2.1 channel. This channel is abundant in the cerebellum and also important in the synaptic transmission. The defective gene is the CACNA1 gene. Up to now, there are more than 100 pathogenic mutations in the gene is identified. It's transmitted in autosomal dominant pattern with incomplete phenotypes. In summary, the onset in the childhood or it can be in adulthood, when it can be in the sixth decade. I put in the red color the more frequent one. So the childhood is more frequent onset than the adulthood. During the attack, they develop episodes of ataxia with the dysarthria spells, and associated with that some get brainstem symptoms like diplopia, vertigo, tinnitus, some get migraine. Migraine is noticed in around 50% of the people, including hemiplegic migraine. Seizures, dystonia, cognitive deficit, and the abdominal pain also recognized manifestation. Then other manifestation they mention myasthenia-like weakness, even within the investigation also that is visible with the repetitive nerve stimulation. Then duration of this episodes of ataxia lasting hours to days. Triggers of the attack also similar to episodic ataxia type 1. That means physiological, psychological, or startle, kinestogenic movement. Likewise, same triggers are there. Now, difference is in between attack. These people have nystagmus. It can be primary position, downbeat, or gaze or rebound nystagmus. In between attack, they can have EEG abnormalities as well. Likewise, in the EA1, EA2 people also, as the disease progresses, can develop persistent ataxia with the cerebellar atrophy, that is with the time. And in an adult patient with the EA2, if we look back into their past medical history, as a child, he or she might had episodes of paroxysmal tonic-cup gaze or benign paroxysmal torticollis episode. Existing treatment. For the, I like to stress again, this is only education, not a medical advice to get any treatment, okay? And existing treatment, as for the EA2 acetazolamide, the how it act is it changes intracellular pH and changes transmembrane electrical potential. Other treatment are newer potassium channel blockers like poaminoperidine, POAP, and slow release newer form of the POAP like dalpampiridine and pampridine, and limited stem. And then I'm moving to the genetic aspect. CACNA1A gene mutation, if we do directly, there can be variants of uncertain significance. So, and I like to highlight the fact that CACNA1A gene with a different type of mutation can present with different type of autosomal dominant neurological condition. We'll move to that now. Here, CACNA1A gene with loss of function mutation, they present with the episodic ataxia type 2. And with the gain of function mutation, they present with the familial hemiplegic migraine type 1. And with the triplet expansion within the CACNA1A gene, they can present as spinocerebellar ataxia type 6. So even within the same family, there can be different disease manifestation due to the problems within this CACNA1A gene. And I like to ask two questions. So commonest type of genetic episodic ataxia are type 1 and type 2. Okay. So among them, first question is among them, which episodic ataxia type affect due to a defect in the channel, which we can name with a single letter from the periodic table of elements. And second question is, what is the commonest genetic episodic ataxia in the world? So the answer will be the question number. So first one is episodic ataxia type 1 because potassium channelopathy is happening there. And commonest primary genetic episodic ataxia in the world is episodic ataxia type 2. Now I'm going to tell about primary genetic episodic ataxia types. And I put blue color star for the episodic ataxia type 1 and orange color star for the type 2, and you'll understand why I put like this in coming slide. And I like to tell that episodic ataxia type 5, 6 and the 8, we have identified the relevant gene, but 3, 4 and 7 still the relevant gene is not identified. Then we are moving to the episodic ataxia type 3. And I have put the blue color star so you know it's very similar to the episodic ataxia type 1. Type 3 has identified in the large Canadian family short attack like EA1. During the attack they get vertigo and the tinnitus. Tinnitus is not there in the episodic ataxia type 1, so that is different. Other than that, they also have intact myokymia like episodic ataxia type 1, but this is responding to the acetazolamide. Now EA4. I put orange color star so you know it is somewhat similar to the EA2. See, two families from the North Carolina, onset in the 30 to 60s, resemble EA2 but without interictal nystagmus, not responding to acetazolamide. But we know EA2 is better respond to the acetazolamide, but this is not respond to acetazolamide, and vertigo respond to the gabapentin. Now EA5. EA5 also I put the orange star. You know it's now similar to the EA2. Yes, it's very similar. And single French and Canadian family, and like EA2 respond to acetazolamide. The change is the gene is different. In the EA2 it's CACNA1A gene, here CACN-BPO gene. Now I'm moving to EA6. EA6 also I put the orange star, so you know that it's due to a defect like happening in the EA2. So Here gene is different, SLC1A3 gene. So I like to summarize here. So in this table also I took it from that systematic review I mentioned before. So EA1 and EA3 I put the blue star. So you can remember it's very similar to each other. EA3 has additional nystagmus. EA2, EA4, 5, 6, 7, those are very similar to each other. Somewhere the genes are different there. All those conditions transmit with autosomal dominant pattern. Again, I like to highlight the finding the etiology of the primary genetic episodic ataxia, the importance, because EA1 treated with the carbamazepine, EA2 acetazolamide, EA3 acetazolamide, EA4 gabapentin, EA5 acetazolamide, EA6 acetazolamide, likewise list is going on. That's the importance of finding the etiology. Now we are going to compare EA1 with the EA2. Episodic ataxia type 1, it's a potassium channelopathy, type 2 is a calcium channelopathy. Type 1 lasts second to minute, type 2 lasting hours to days. Type 1, ataxia and the vertigo they are in during the episode, and type 2 during the episode ataxia and the dysarthria spells. And in between episode, in the type 1 they have myokymia. EA2 in between episode they had nystagmus. EA1 respond to carbamazepine, EA2 respond to acetazolamide. So at the beginning I put 6 subheading as outline. Now at the end I like to summarize in this subheading. So first one is importance of the finding the etiology of episodic ataxia, because the most are treatable. And primary genetic episodic ataxia are channelopathies. EA1 is a potassium channelopathy, EA2 is a calcium channelopathy. And I described the story in 1975, how the first description of the episodic ataxia type 1 happened. And in summary, episodic ataxia type 1 is a short-lasting ataxia with the vertigo. In between those episodes, they had myokymia. In 1946, they had the first description of the episodic ataxia type 2. In episodic ataxia type 2, they had long-lasting ataxia and the dysarthria. In between episode, they had nystagmus. And thank you for listening. Hope you learned something new here.